I'm not surprised that so many of you are here this morning because obviously we all have lots of questions that aren't necessarily answered by sort of generic press reports that we read. So I'm really very pleased that Jackie Cassell is able to be here with us and give us a more medical take on the lovely coronavirus. So Jackie now teaches at Brighton Medical School, and we'll give you a fuller introduction, but she's also an amateur musician, and so she understands where we're all coming from. So I think I'm just going to hand over to Jackie and she will tell you more about herself that might be relevant to this discussion. Jackie.
Hi, thank you very much. It's a real pleasure to be here today. This is one of my other lives. My mum was a music teacher and I hung around all kinds of music for years and years and years and years. And I've variously played a bit of trumpet, nearly went to violin, studied violin, and still do a lot of music and kind of been quite involved in the infrastructure of it. So I tend to be the person who does I do some catering in the orchestra I play for, and I help with all the kind of organisation. So it's been, but my background at work is that I went into the field of public health, starting off in sexual health, sexually transmitted infections, and one thing leads to another, and I've been working in recent years on outbreaks of infection in care homes, particularly around scabies, and I've written a bit about that on my blog, which I think Sharon is going to share, but I've also worked on contact tracing for sexually transmitted infections, and both of these are kind of niche areas that some of my colleagues thought, well, why are you working on that? But all of a sudden, those of us in sexual health find ourselves very close to the kind of understanding that we need to have. I mean, as you know, there was a lot of emergency planning, what will the next pandemic look like? And the government in Operation Cygnus modelled influenza. Now for influenza, which in the West, people thought that would be the next big epidemic, you can't really do contact tracing, and you can't, it's just not feasible or helpful. So I think for coronavirus to look as it does, and to have such need to be sort of thinking who sits next to whom, and how do you work out, backwards tracing who they might have got it from, and so on, was a real surprise, I think, to many public health people, and as is clear, we weren't very well prepared for it, and in China, taking very different approaches. But I found myself sort of getting drawn into advising in various ways. But of course, what I've started writing my blog about, it's the kind of stuff that my family and friends ask me, because I spend a lot of time sitting in meetings where we're looking at the data on this and sort of thinking, what do we do, and how's things going in the hospital that I'm on the board on. But I'm really early on, I got very interested in what this means for my musical friends whose lives have been completely devastated by this in quite a strange and unexpected way. And this kind of like virtual worlds that we have are, very good for some things, but a real loss. And so I started reading about some of the choir stuff, and I think I'm just going to put up, many of you will have come across this, but I'm just going to talk a little bit about, briefly about this outbreak in a choir in America. Just show some data, just show two nice visuals from it, and then sort of talk a bit about really why choir stuff is so interesting and so complex. And then we can have a discussion about, where next really for different sorts of amateur music. Because I think although people get very concerned about singing and aerosols and so on, actually a lot of the issues are very generic, whether it's a tambourine band or whether it's a choir. So this is the first paper. It's linked to on my blog, and Sharon will put up a link to it. But this is a paper that was published last year. Has it come up for you now? Yeah. So this is about an outbreak at a choir that rehearsed twice in early March last year. It's freely available. It's a very good quality report. And it's a very famous publication, Morbidity and Mortality Weekly. That's the kind of Centers of Disease Control, American disease control centers. They're really excellent, and this is kind of reminds me rather of the report that came out 1982, I think it was, for the first few cases of what turned out to be AIDS. So these outbreak reports are really interesting and very important. You look back at them and you get to understand a lot. So this was a terrible situation where one person attended and proved to have coronavirus, and 87% of those attending were either confirmed or thought probably to have had coronavirus. So the white is the people who were not affected, and the yellow is the people who definitely or probably had it. And this was what we call the index case. And I'm going to click on the figure now. So this is, if you're doing sort of outbreak control, this is actually a really beautiful graph. It sounds terrible, but it's actually a really nice graph, because what it shows exactly what you want to see if an infection happens at a single point in time. You've got this index patient who got their symptoms, and then few days later, over a really quite a small period of time, all the confirmed and probable cases got ill. And this was the last person who developed symptoms, and that was a probable, so may or may not have been coronavirus at all. So what they talk about in this very nice article is just how they investigated it, and they were clearly there's lots and lots of cases popping up here and there, but you can learn so much from these from what they call a point outbreak. So they looked at this choir, which had a rehearsal on the 3rd of March and the 10th of March, and one person had just had a little bit had cold symptoms and developed, and clearly this got round a huge proportion of the choir. As you can say, the vast majority were affected. And so if you look at that, so I look at that choir practice and I think, well, how do you get that? It's very unusual to have such a high attack rate. This is kind of higher even than you might expect household transmission to be. So you look at what happened in that choir. They had a rehearsal that went on from 6:30 till 9 p.m. Various people arrived early to set up chairs. 6 rows of 20 chairs, placed 6 to 10 inches apart. There was 40 minutes full choir rehearsal. Then there was a 50-minute sectionals. And then they all came back together. There was a 15 break at some point, the 15-minute break before they all came back together, with cookies and oranges on a table at the back of the room. Everybody put their own chair back and hung around talking at the chairs, and they had a map of exactly where everybody had sat. And so this is the kind of circumstance that makes people so incredibly anxious about singing. However, obviously, I mean, and I think that's a pretty singing heavy schedule, but actually what we do in choirs and orchestras and so on is a huge range of things. There's the transport. How do people get there? Do they share a car? Do they travel together? All that kind of stuff. There's the going to the toilets and so on. And every concert and rehearsal I've been at, there's a queue of like 20 people for the toilet, and they all have to get in and out within about 5 minutes, which is a bit of an infection control nightmare, which of course, and that isn't actually mentioned, interestingly. And then there's the fact that usually, and we did a survey around this, I was trying to put together some research earlier last year. How's the catering done? Typically, it's amateur catering, where some people will bring some things. It's somebody's birthday, that will be put out, might have some cake. And so it's in terms of the different sorts of exposure that you might have to somebody who's affected, it's really multiple. And it's also a building which other people come in and out of, possibly during the rehearsal, that is used for other purposes. So very few choirs have their own space, probably King's College Choir, and that's about it. So it's a really interesting challenge, but it also it's kind of raised a huge amount of anxiety. And so, and it ties into these questions at the moment about, should we be wearing masks outside and all this kind of thing. And I think this is a really interesting from an epidemiological point, because what they call this is a super spreading event. So the real worry about orchestras, choirs and so on is that you might get these super spreading events because you've got people very close in multiple ways, traveling to, traveling from. What does all this mean? So I just wanted to put that up, and we can have a discussion sort of starting with that. And the graphs are available if you click on the link to this paper. You can see the figures and the tables on the side. It's only 5 pages, so and very readable. So I think I shall hand over to Barbara to run the discussion however she wants. So the catering, they don't just specifically state that, but there wasn't a kind of major catering. It was cookies and oranges at the back. It doesn't say that. Interestingly, though, and I don't think these were choir people who wrote the report. They didn't say whether they were homemade cookies or that kind of thing. So, was it 10 different people bringing in cookies? But they don't get to that level of detail, interestingly.
Sorry, unmute myself. Yes, that would be helpful. Yes, so before we go to any questions, I mean, since that outbreak, obviously, we think we've learned something about the transmission routes, both through things that you touch. I'm just going to say, I think fomites that are on surfaces and aerosols. Is there anything new there that we should know about at the moment?
I don't think there's anything throughout that's come up that's particularly new in terms of how you get transmission. Obviously, there's a concern about whether the new variant is more infectious, and we might talk about what that might actually mean in practice. But there aren't any new transmission sources. And I think maybe it's worth talking about what they do and don't mean by more transmissible. And again, I've got a blog about that. So in what way might any new variant, and there will be lots and lots of new variants over time, what would make it more transmissible? So one thing is it would be more sticky to cells. So if it lands on, the cells of your nose, the cells of your mouth, the cells of your lungs, is it stickier that gives it longer to be picked up and pulled into that cell? Or are people infectious for longer? So when you're looking at something, and you saw on the graph that pretty much everybody had developed their symptoms by 7 days. So, but if people were infectious for 1 day longer, say, that might make a bit of a difference. Another thing that would make a difference would be how much virus you have on you. So given that if your surfaces, your nose, your mouth, your lungs, just have more virus on them, that means that per droplet that lands on somebody else, there's going to be a greater chance that if that gets touched and put into the mouth and so on, that there will be enough virus for somebody to get ill. There's a thing called the minimum infectious dose, and so that's pretty low for. It's pretty low. The most infectious thing is norovirus, actually, winter vomiting. But the infectious dose might vary a bit according to how sticky it is to the body. But what isn't going to happen and hasn't happened is you look at something like measles, right? I would not want to be in the in a room that somebody with measles was in a few hours ago, because it's got aerosol as a major source of transmission. What hasn't happened, and there's no evidence for, is that the predominant mode of transmission is changing in any way. So I remember, again, in the early days of AIDS, people would say, oh, what it becomes respiratory. That just isn't the sort of thing that happens. You know, the organisms change within the type of organism they are. So I think that's although it's very likely we will have changes of what the vaccine needs to look like in coming years and so on, then it's not going to change radically in terms of the sorts of things that we do to prevent working. All the things that we were told to do last year work, but a large number of people do jobs, have caring responsibilities, have things they have to do in their lives, which mean that they have to go out and do their job. And a lot of the infection going on now is where, you know, you can keep a workplace safe, but you can't, if people are sharing cars, which they need to get to job, and a job that they will lose if they don't turn up. A lot of that transmission is what you call at the edges of the workplace. And I think it's also worth saying that one of the reasons people don't want choirs or whatever social gatherings to happen is because it's quite easy to make, you know, you've seen the London Philharmonic and so they've done these lovely videos with their brass and they're all kind of socially distanced and so on, but it's on the way to, on the way back, the informal contact. A lot of the transmission risk is around that. So I think, and that in some respects, that's a particular challenge for the music industry. So, you know, if you're going to Superdrug, all they've got to do for their customers is get them safely in and out, and that's a relatively straightforward operation. So, but in a choir is many things for its participants. People come for all sorts of reasons, and there's no single one. But a large part of it for many people is that particular way of socialising, and that I think is going to continue to be something we'll think about. For example, I used to do a buffet dinner for my orchestra, which we'd have just before the concert. Buffets are not going to come back in catering for a long time, let alone amateur catering. So anyway, I'll stop there. I hope that answered your question without drifting off too far, Barbara.
No. That was really useful because I've been wondering what makes something more transmissible. You know, we're told it's 70% more transmissible, which seems like a really precise figure, but we don't actually know, you know, how we need to act to stop that. Do you see what I mean? So I think that's really helpful, and also really helpful what you're saying about transmission around the edges. And we hope, as we've written our risk assessment guidance for groups, that we have taken that into account, including who was in the building earlier. You know, so was there a nursery earlier there, or is there the scouts after you? You know, all that kind of thing is relevant. So that's really helpful. Thank you. To talk about that. I wondered whether we might just talk about vaccines. Do you know anything about vaccines, Jackie?
Yeah, I mean, I can't quote every precise figure, but I understand the strategy and I understand the vaccine sort of, yeah, what it's like, what sort of things we know, what sort of things we will know on what timeline and so on. Yeah.
So that it would just be helpful. I think people are wondering, you know, how helpful are the vaccines going to be? Is it after a first dose or a second dose? How many of a choir need to be vaccinated before they can safely meet? I mean, these are questions that I certainly can't answer.
Yeah, I mean, the government is clearly taking a very specific, a very particular line at the moment, which I think I fully support, which is that they're saying we don't know to what extent these vaccines will interrupt transmission. What does that actually mean? So looking at the size of this call, somebody on this call probably had chickenpox twice, you know, but most of us didn't, and nearly all of us would have had chickenpox at some point. So it's the same sort of issue. Does a vaccination make you does it stop you transmitting? Does it mean that if you get it, will you get it again? Is one question. Will you get it again? And if you look internationally, there are a small definite numbers of people who've had coronavirus proven twice. It's small, but it's there. And whereas for measles vaccine, you know, that's pretty complete if you've had a full course. So the question is, could somebody who has had the vaccine then become infected and infect somebody onwards when they get it a second time? So it's quite a complicated question. Does it stop transmission? So the sort of data that we hope to have in by April will be through looking through at the people who were vaccinated during the trials. They will be continuing to follow those people up in cohorts, and also people who get sick, following them up, and then saying, okay, what's happening in terms of whether we find virus on them again, 3, 4, 5, 6, 7, 8, 9, 10 months time. And then you need to say, well, what was the attack rate for the people you'd expect to get infected? So let's say they live in a household where you'd expect one case to produce, you know, 3 other infections. Is that happening? So you've got to say, do they get it again? And if they get it again, are they actually shedding enough virus for somebody else to get it? So those are the kinds of studies that are going on at the moment, which will give us an answer to, which will give us an answer. The likely answer is they won't protect people completely from getting it again, and it's likely that we will have to tweak the vaccines in the coming years, but it will make it much less likely if you do get it again, that you will not be carrying so much virus. There are a few infectious diseases. One is dengue fever, where if you get it again, you get it worse. So of course that was a big worry. But the evidence so far is that if you get coronavirus again, you tend to get it more mildly.
I keep muting myself in between. So I think that's really interesting. So Sharon, hang on. At this point, is it good to pause for any questions that have come up? Sorry, I haven't been able to keep an eye on the chat at the same time. So
Sure.
we're dealing with transmission and vaccines as the 2 things we've already talked about.
Sure. So I may possibly ask some questions that you've already answered, but if you have, please just say that. Have there been similar studies of other choir rehearsals with different patterns of activity that might show whether singing is the issue or whether it's personal contact or surfaces, etc.?
I think that's the only one I know really well. There have been a number of documented outbreaks, but they tend to, and which somebody's kindly put in the chat, they often tended to be quite a lot more complicated, like involving a concert as well. So I think it is quite hard to get to the bottom of what, I mean, I'm sure this is multimodal transmission in a setting where you've got multiple different sorts of contact. But I mean, they don't document the transport patterns there and back. It's, you know, it's America, it's going to be cars, isn't it? But no, I'm not. But this is you know, this is very characteristic that they couldn't really, they weren't able to say it was just the people who were next to them. You know, there's clearly a complex transmission context in all of those outbreaks.
Right, thank you. Yes, I think the other one that was that has been referenced in the press or something was one in Amsterdam, but you know, there wasn't such an in-depth study on it, I don't think so. But so this is that what I'm taking away from what you're saying then is, you know, that people have kind of dramatized the singing bit, but actually there are so many factors that play into how it can be transmitted when a group of people meet for whatever reason,
Yeah.
that actually it's not at all a given that the singing was the major contributing factor.
Yes, and it's very, I mean, it's very striking. This was written fairly early in the epidemic. It was published, you know, it was published in May of an outbreak that occurred in March with the follow-up, so it came out pretty quickly. They don't really talk about ventilation, and you know, and ventilation is tied up with proximity. So if you are in a house with somebody, you know, it varies the extent to which you will infect your, you know, people in your houses, but ventilation is a big factor. The amount of space you've got is a big factor, and that seems to be true for all the modes of transmission. It means that droplets dry out quickly. The way that viruses die is basically they dry out. They are kind of soggy crystals, and when they dry out, they no longer have the properties that allow them to get into cells. So you want things to dry out and be swept away, and you want door handles to be washed and all that kind of thing. But I think yeah, so you have to be thinking about all those things. And interestingly, this, you know, respiratory infections in children and older people, you know, flu and flu and all the kind of standard respiratory virus, all that has gone down this winter. So, you know, this is a kind of generic thing. You know, some people's, I think housing policy and public health is, you know, we're thinking much more now about how housing and physical environments affect respiratory disease transmission. So one of the lessons with coronavirus is that a lot more respiratory infection may well be preventable than we've tended to think in this country.
That's very interesting. And so my theory is that sorry, I'm originally German, you know, that the Germans are really big on ventilating everything all the time. So maybe that's why they got off more lightly initially, but they're obviously not coping well now. So it's maybe not opening. So turn the heating on and open the window. Is that what you're saying?
Yeah, turn the heating on, you know. I think that's quite a complicated question, actually, because so I would think is make sure there's ventilation. And I mean, I think we will. I mean, I'm not an expert on ventilation. If you want a really good person to follow on ventilation, she's Kath Noakes, and she's on Sage, and she's got a nice Twitter feed. I've just put her name in the chat, and she is. There are some ventilation papers which I will dig out later and send to you, but it's slightly complicated because some sorts of ventilation then sort of blow a lot of stuff around. So I'm not going to give a straight answer to that, but I would just say open the windows whatever you do.
Okay, great. But the heat would also dry out. That was what I was getting at. The drying out is not something I was that aware of. So thank you for pointing that out. Sorry, Sharon, back to you.
Yeah, there are 3 different questions about distancing. So I'm going to ask all 3 questions. The first question is, does the 2-meter rule make any difference to transmission? The second question is there any evidence of a safe distance for singers to be when they're not wearing masks or visors? And the third question is, what conditions will need to be met before we can have an indoor audience without the 2-meter distancing? Could you possibly speculate when this might be possible?
Okay, I mean, I think one would have to be pretty brave to predict anything at the moment. But 2-meter rule, I mean, where does the 2-meter rule come from? So it's an observation that in all the many outbreaks where you've known who got it from whom, or what the episode was, does it seem to have happened within 2 meters in normal circumstances? And we think that 2 meters is, you know, 1 meter is safe outside, 2 meters is safe in most circumstances, 2 meters is safe indoors. That's simply observational data. There have been some suggestions of challenge studies, and I'm not so much on top of that. I think one of the things that it's important to recognize is that it's how long virus survives and can get into you in whatever mechanism that is. So we know that droplets, which are quite large and have a lot of virus on them, you're unlikely to get one of those land on your face 2 meters away. It's certainly true that aerosols, so droplets are, I can't remember how many microns, and they're kind of balls of mucus and virus and everything that comes out of your nose and so on. And then aerosols are much tinier particles, still suspended in fluids. So you've got a tinier amount of virus, and it will dry out quicker. Somebody else will get that, don't worry. So they dry out quicker. Sorry, my other phone. Yeah, sorry. So what appears to be the case is, although there have been aerosol associated outbreaks, not including some sort of Far Eastern ones where they've got like really detailed CCTV coverage of a restaurant and so on, there have been some aerosol only outbreaks, sort of a family at a different table where they hadn't been, you know, there's no reason to think that they had been closer in any way. What's really quite interesting is that even though people have been wearing masks and not having rehearsals and all this kind of thing for such a long time, there haven't been a lot of proven aerosol only outbreaks. They remain rare. And they remain rare in places where they've sort of gone back to, you know, different patterns of social distancing, and in China and so on. What that does mean is that the risk is very, very much lower over 2 meters. But I mean, I know in the press you've got Trish Greenhalgh at the moment, sort of, she's very heavily lobbying for 3 meters and all kinds of constraints, but it's just not borne out by the outbreaks that we're seeing, which isn't to say the risk is zero. You can have a peculiar ventilation pattern, you know, you can have bad luck, but 2 meters seems pretty safe. But I don't think anybody's really going to, you know, I think what's really difficult is that there's a lot of these things that we're just never going to have terribly good answers to. So we can say, well, you know, we're just not seeing where there is high prevalence, and we're seeing these patterns, and we actually know what people were doing, and we've got CCTV and so on. We're just not seeing transmissions within 2 meters. And then you've got things like this choir outbreak, where clearly you've got so many things going on that you can't disentangle it and talk about 2 meters or 1 meter or anything. I know that sounds very, but I think that kind of uncertainty, it's important to, like, it will remain.
Thank you. I think that's great. And yes, I think the indoor audience says nobody's speculating on that. That's too tricky. Sharon, do you want to carry on? Is there stuff
Sure.
that...
There's a few questions, again, if I read them all out at once, I hope that's okay. There's a few questions about vaccines. So given that vaccination does not give 100% immunity, and that some choir members may choose not to take the vaccine, this obviously means some choir members will still be at risk from the virus. Will we be required to take all of the same precautions in future, such as social distancing and masks? Somebody else has asked, is it true that we don't know how far being vaccinated reduces the risk to others? Should we ask members to let us know if they've been vaccinated? Should we consider turning away anyone who won't or hasn't taken the vaccine?
I think there's going to be some quite interesting civil liberties and other debates taking place over this, really. I mean, I don't know which way the kind of vaccine passport things for various purposes is going to go. I think I think it's likely that by April there will be a very clear idea of just how much risk is associated with. So let's say somebody's had their 2 doses. What's the chances of somebody like that actually being a source of somebody else getting infected? So let's say I've had vaccination now, I get COVID 3 months' time. Am I likely to pass it on? We will have good data on that. And I think, I think, you know, when you look at the distribution of people who've got very sick and the proportion who've died, then I think it stacks up very, very differently in different age groups. And it's true in that Skagit County outbreak as well. So the objective of the vaccination program for current purposes is to make everybody who, nearly as many people who are more likely to get ill, which is people who are 60 plus essentially, plus a few younger people, just to make them not vulnerable. I think it's quite likely, given the culture of this country compared to, say, China, that it will not be made compulsory. And I think, you know, I'd be happy to come and talk about it when we do have the transmission data again. I mean, I think there will come a point quite quickly where people who have themselves had 2 vaccinations can feel fairly confident that they won't acquire it should there be somebody else present who won't. But I don't know when that will come. I think it will be a really difficult, really challenging, it will be really challenging for the music sector. But I think, interestingly, because the age group of most, I mean, again, this paper, like the average age of the choir was, what was it? It was mostly women, and the average age was people who got sick, median age 69, median age of those who got ill was 69, and 85% of cases worked in men. And so the people who, so I mean, you know, there's no definite answer, but I think that waiting for the transmission data, and everybody expects that the transmission data will be reassuring. I think that's the point at which it will be possible to think what kind of look like sensible measures and what look like really coercive and excluding measures. You have to think, what are you trying to prevent in your choir or whatever it is? What, you know, what do, maybe put right in the chat, what do you think it is that you want to prevent? So if you're as a choir, as a leader, and then as an attender, because there's different set of issues for you. Barbara, I don't know if you want to.
Yep. Yeah, no, I think that's absolutely right. That you know, even before in September, when some groups returned to activity, we said the first thing you need to do is survey your members to find out what they want, feel comfortable, or don't want to do. And as expected, there's a percentage that's larger or smaller in each group that didn't feel happy to come back. But yes, like you say, what are you trying? You're trying to prevent your meeting, you know, causing lots of people to get ill and possibly some of them to die. So that's what you're trying to do, and therefore you need people to realize that you can make the activity as safe as possible, but you can't control every factor. You know, as you said, there's so many that come into play, and that therefore they need to carry personal risk if they're coming to this activity. So I mean, that's what we ask people to outline. It's not quite signing a disclaimer, but you know, to say there is always, you know, if you go to the shops, there's a level of risk involved, because there may be someone there who doesn't wear a mask and it's a tiny corner shop, you know, whatever. Yeah. So there's lots of factors, isn't there?
Yeah, I mean, Chris Whitty pointed out that we have an idea of, in some sorts of year, that, you know, how many thousands of people would die in a normal year from influenza, and what's a bad year and what's a good year. And clearly this year and last year are good years for influenza. But we've never thought about influenza in choirs. Now, most people in most choirs will be offered an influenza vaccine, and they might or might not take it. Now, obviously, this is kind of that much more dangerous disease, but nevertheless, I think there's a whole thing about health and safety, and, you know, in various sorts of activities in multi-use buildings, which we've never really thought about, but we can probably do quite a lot better, both preventing kids from getting respiratory illness in a multi-purpose building they go to nursery with, but also older people going to a choir. So I think I would see this as a bit of an opportunity to rethink how we do safety in communal activities, which isn't to say don't do them, but I think we're going to be much more aware and think much better. And, you know, it's very, you know, I do a lot of work on the care sector, both home care and social care. Nobody's really thought about flu vaccine uptake in care home, in home care workers. They have in care homes, but, you know, there's no system for helping people get that. So I think that there will be a whole load of systems for beginning to think better about infectious diseases that will help us all, and we'll all get much more used to thinking in that kind of very uncertain space. I mean, that's the thing about infectious diseases. They're socially transmitted and they're scary and you can't see them. So there's you know, so I think sort of as a society, we will probably get better at thinking about those things beyond coronavirus.
Brilliant, thank you. Sorry, Sharon, did that answer question, or was there something else about vaccines?
No, that's everything about vaccines at the moment. What I'm doing now is I'm going back to the beginning of the chat and picking up all the questions that we haven't asked yet. Okay. Interestingly, the first one I found just relates to what you were just saying, Jackie, which is that earlier, back at the beginning of your talk, you said that contact tracing wasn't feasible for influenza. Can you explain why that is so?
Well, influenza is kind of quite aerosolized, and it can spread quite a long way in the air. You don't need big doses, and it's just not possible to, because it's very easy to get in many public settings, and people get onset of symptoms quite quickly. It's very difficult to work out how they all got it, and there isn't any sense for contact tracing to work. You've got to think, what is it I want this person not to do or to do? So in sexually transmitted infections, let's say it's gonorrhea, it's, well, I want you not to have any sexual contact with anybody until we've treated you and tested you. And we, by the way, we'd also like to test you for syphilis as well, say, or an HIV and so on. Whereas the kind of what you would do with somebody with influenza, given the length of the asymptomatic period and the kind of degree to which it's spread socially, quite casually socially, you know, without having to be very close and so on, then there's just not anything that you would do to control it. Whereas for coronavirus, I mean, it's difficult at the moment because the prevalence is very high. But if you've got a lowish prevalence, as will happen with, you know, once we've had the vaccinations got through a certain state, then you can start really working back and thinking, well, where did this person get it from and what kind of an incident with this, and then put other people into quarantine who are in that, as you saw, there was that 7 days. Most people got symptoms within about 7 days of being exposed. So you've got long enough to do something about it. So it's the balance of length of symptoms, visibility of symptoms, and what you do. So that's, you know, contact tracing is really something that we do for TB and we do for viral hepatitis that might be sexually transmitted or through needles. And we do it for syphilis and we do it for HIV. But most infectious diseases, you know, you don't do that. So respiratory, and when you talk to the mathematicians who do respiratory work, whereas in sexual health, we've always gone, okay, there's some people who have like one sexual partner for, you know, 30 years, and there's other people who have quite a lot of partners. And so when you're thinking about sexual risk and who you need to reach, you're looking at people very differently. Whereas for respiratory, yeah, there's going to be a few people who don't go out much, but basically any of us going out into the shops is going to look roughly the same. So you don't have this kind of highly differentiated way of looking at it. And one of the things, I mean, my most recent blog on my website is I'm talking about the large numbers of unavoidable contacts that you have if you're in an insecure job or you're doing health service or social care and so on. And so that whole, you've got, you know, you can describe the pattern in most respiratory illnesses, they're just not that, it's not that easy to hone on where in a sufficient time span. That's a long answer, I'm afraid.
No, so Jackie, you're saying that I mean, just like coronavirus, most influenza is also asymptomatic for a period when it's already infectious, right? That's what you're saying.
And it's a short period, and a lot of people will be pretty uninfectious, and it's also something that you can get. I mean, it's more aerosolized than coronavirus tends to be, and so, you know, you just don't want to be on the tube with somebody. You know, you don't want to be in the same carriage as somebody sneezing with flu.
Yeah, no, so I mean, one of the things that always struck me when my children were small is that, you know, perhaps we could start by not sending children to school when they're, you know, they're actually quite ill, you know, but that's always quite difficult for parents as well, you know. So like you say, jobs and childcare and things, people potentially could help all these diseases, right, by not mixing with other people when they definitely know they've got them.
Yeah, and also there's probably a bit more we can do about household transmission, and those of us who have bigger houses can do more. I mean, there's some very interesting paper stuff which I'm sure Kath Noakes had written. I've linked to it on my my last blog, the one that's at the top, but it's about what, so if you must have a family Christmas, what are the things you can do? And it's things like opening windows at night but not opening doors into a corridor and all that sort of thing. And I mean, it's interesting. I mean, the message is very much face and space and so on, but all the very complicated things you can do within a household, I think, are really quite highly applicable to those of us who are looking to resume social activities. So I wrote about, for example, how do you have someone shielding to visit when shielding ended in August? Because, you know, I had friends who were really terrified of having anyone in or terrified of going out. And so just how do you manage those things? And I think, you know, the sort of guidance that restaurants have been operating under so that the staff who go between lots of tables don't pose risk have been, you know, if you looked at environmental health regulations a few years ago, or even like a year ago, there was nothing about the risk that the staff from the restaurant itself posed to the clients. And of course, I mean, food hygiene was all about the food, the food risk to the clients. And so that whole sort of way of thinking, I think, is just completely new, but it's likely to be very effective and very applicable in many areas of our lives, actually, I think.
So hopefully in future we will be less ill, and there might be a lower than average death rate once we get over this terrible thing. Okay, um, so right,
So someone
sorry.
has actually just asked, Jackie, are you saying that the government and SAID strategy on track and trace was always a waste of time?
No, well, I've written about it. I think that the way they did it in the early stages was really a disaster, because what we have three groups of professionals who do contact tracing in the UK. One is people in what they call health protection teams, public health people employed by Public Health England, there's a local team. Then environmental health, they'll do things like an outbreak of salmonella that might be affecting food or whatever. And then we also have the sexual health people. So we have people who are used to ringing people up. And so instead of sharing the information with those groups and scaling them up to train the next people, the whole thing was outsourced. And it's actually, it's not necessarily an objection to outsourcing, but what they didn't have is the expertise, so that when we had really quite low rates by last summer, and obviously summer is a particularly easy time, that then we didn't have competent, experienced people. So for example, I used to do contact tracing, and you get a meningitis outbreak and there's a 16-year-old being admitted to hospital, and you want to work out who's a household contact. Well, it turns out that people weren't sleeping where they said they were, and all this kind of thing. And and it becomes quite a big challenge quite quickly that you have to be very discreet about. I think the other thing that has been really a disaster is the lack of support to isolate for people who can't afford to. I'm sitting at home working here, very comfortable too, but if you have to go out for work and you'll lose your job if you don't turn up and so on, what is the incentive? And there's a data that something like 70% of people are turned down for the £500 payment. And so there's the competence of the people, and obviously you can't scale things up without recruiting it, and maybe that's fine to outsource. But what you also have is the financial support. And if you look at some areas, if you look at the Isle of Sheppey, where I come from, 3% of people do more than 50 hours unpaid care for somebody else, and the poorer the area, the more that is going to be the case. So that means that somebody is both, what happens with that if you can't go to work and you have to quarantine? So I think the whole social support for isolation and financial support has absolutely not been adequate, and it's particularly not been adequate for people who live in the most straitened circumstances, and I think many of us have gone on the record to say that.
No, absolutely, I totally agree that they can't afford to not get, to keep away. So I was just going to say, there was a question I think about this as well, is tell us about face coverings and singers, or in general. Is there something useful that we should know?
Yeah, I think it's important. There is evidence that face coverings they are source control, and particularly important in crowded indoor settings, and they have a function there. It does protect to a degree, not perfectly, staff in hospitals. There is evidence that it can reduce transmission in care homes and so on. It clearly doesn't completely prevent, and then there's all sorts of stuff about handling that, but it's clearly recommended in some settings. What I would say is, once we've got the vaccination program to the point where most vulnerable people are no longer vulnerable to getting coronavirus, then I think there's a real question about what its value will be then. I think there's a whole lot of kind of very coercive stuff. I think we need to recognise that many people have communication difficulties of all sorts, from deafness to autism type things, all sorts of things. And I think my personal view is that the strong evidence that we have for face coverings for certain very high risk settings should not be translated into making them mandatory in settings where the evidence is that, you know, distance is enough. I think this has been enormously damaging to the disability charities have been absolutely shocked by the impact this has had. So in terms of, I think if you don't feel safe at 2 meters in a well-ventilated place, it's difficult to see what a mask would add. It seems to me that risk is always kind of quite holistic. And I think, you know, this is a question for the community, really. I mean, what do people want to be doing? But I think there will come a point where people take very different views on this, and that'll be partly, you know, temperament and character and experience in their family of, you know, all sorts of stuff. But I think it will be important to get to a point where even if some people want to do it, it's not, you know, we need to be clear there are circumstances where it won't make a lot of difference, and we don't need to, I think the evidence is not going to be good on that, and it will continue not to be good. So I think that uncertainty is something we need to live with and not fall out over.
Yep. Yeah, no, absolutely. And I think it's we think you know, for the way we describe it, I hope it's as part of a set of measures, you know, to control that multiplicity of problems, you know, whether it's from ventilation to everything else at the moment. And luckily, you know, there's singers masks, which I think most people have discovered, that give you a bit more space. And I've now discovered a mask for my trumpet playing, but only made in America. It cost me an absolute fortune. I'm just trying to encourage someone in the UK to start sewing these. So they've got like a slit, and you can just put your mouthpiece in, but it keeps the rest of, you know, it stops any aerosols kind of leaving at that point. And obviously you've got a bell cover that you can put at the end of the trumpet. So so there is those kind of things that you can use.
Can I ask, so for your trumpet, what do you do about the little water valve at the bottom?
Well, I mean,
that seems to me that's the dodgiest bit of a trumpet.
Well, we were instructed, and everybody started, you know, that obviously, you know, when you come to rehearsal, we had a few meetings in the autumn, that, you know, you collect that either into a separate plastic pot or on a towel that you then put in a plastic bag and take away with you. So it's not touching any surface, basically. So yeah, it is an issue. Sorry, I've distracted. Sharon, tell me questions.
Yes, there are 3. Sorry, I've actually just written them down now so I don't lose them. There are 3 questions from quite a way back in the chat that we just need to pick up on. The first one is, what is the lifetime of the virus outside the body?
It depends what it's on. So on, for example, paper or fabric, it will be 2, 3, 4 hours. And, you know, it depends on temperature and dryness and all those sorts of things. And on something like, and where it's on a cold, non-drying surface like metal, then it will last a lot longer. So about 24 hours, up to 24 hours. And so that may be part of why sort of cold rooms and abattoirs and all those kind of very cold, moist workplaces have seen big outbreaks. That may also be the kind of work that's done there. And if it in UV light will dry it out much more quickly. So if it's outdoors and you're in the garden and so on, then much. But I think you're looking at so it's very, very dependent. But I think looking up to after 24 hours, you'd have to have quite special conditions for it to persist in an infective form.
Okay. And then the next question is, someone said they've heard you can get an antiviral fog that you can spray into the room. Can you offer any comments on whether this is a good thing and how well it works?
I can't, I couldn't offer any competent comments on that. I do know that, and Catherine Oakes recommends certain sorts of, if you've got a really poorly ventilated room, there are certain sorts of extractors that are good as long as they're actually extracting. But she would say, well, mostly just try not to be in places that are poorly ventilated and find ways to ventilate them.
Yes, and there's people, I mean, I suffer from lots of allergies, so, you know, the idea that someone's just sprayed a room and I'm going to spend some time in it makes me come out in a cold sweat already. Okay, Sharon?
Yeah. Here's an interesting question. Why do you think our mortality rates are the worst in the world?
Okay, so we have quite an old population. So when you're looking at death rates from anything, you do what's called age standardization. And so you look at how many people at different age groups. And that's quite interesting anyway, because if you look at London, it's got a much younger age profile than most other places. Most other places you see the effects of the the post-war boom and all that kind of thing, but London you don't. So if you look at, so the correct thing to compare would be for age standardized population. So we've got quite an old population. The average age of somebody living in a care home is about 85. People survive, so that's part of it. I think another aspect, which is when you look at, I was looking recently at sort of what's good design in care homes. It's proximity, sit people next to each other because they're a bit deaf, things not being far apart. CQC has always inspected on to what extent you have people coming in and out. We don't actually know. A lot of people. It's probably someone on this call who does choirs in care homes and so on. So we've got these very intense settings where older people live, and they are going to be vulnerable, and thankfully they're all getting vaccinated now, and we've got an older population, and we've also had we have had a resurgence of virus. I think there are a number of changes in the summer which we've had a lot of reversals of the public messaging, and I think even though we would certainly have had a big surge this autumn, it's not been helpful that we've had a lot of sudden reversals around Christmas and so on, and those have kind of perhaps not helped people behave as much as they could. But I would say biggest thing is that's very different from us and many other resource-rich countries is the way that we have supported people in the gig economy which they haven't been supported, and they're not isolating and in the numbers that we need them to. So I would say those are the big ticket items. And is obesity. Well, yeah, I mean, so obesity is one of the risk factors for getting very ill. So is diabetes. So all sorts of things. I mean, I think, so if you are poor, the least well off 10% of the population live 10 years less, and they have 20 years less of poor health, right? So when you compare to Sweden and Denmark and the Netherlands and so on, the kind of discrepancies in disability-free life and in life are not so extreme. So yes, obesity is an issue, but it's absolutely a deprivation issue and all that kind of thing. I mean, I think it's been very interesting to see how we think about how we come out of this from a public health point of view, because I think it's certainly made visible the difficulty for many people of not getting infected, not getting sick. And standardization has a fact that, I mean, this is quite a complex question. There's quite good data on, I will follow that up and get some data on that. And of course, there's also the kind of where are we in the epidemic, how far into second wave and so on. So just trying to look at the chat questions. Yeah, I mean, discharging people into care homes. And I think the other thing I would say is that I ordered a whole load of sort of books, ancient and young, on hospital design and so on. So there's a nice book on hospital architecture I was reading, which was saying, comparing how much space per patient was being given for different hospitals being built in different countries in the 1960s and 70s, and many of those hospitals are absolutely the estates now, let alone the hospital down the road from me has still got the kind of 19th century Nightingale wards. I think it's fair to say, so there wasn't much testing in the spring. There wasn't the availability of testing, but also our hospitals, compared to many other countries, have much less separated accommodation, and that, so obviously if you've got somebody, you know, we've always had beds for people with, you know, multi-resistant TB and stuff, but generally our beds are much less separated than in many other countries. That is the culture of hospital design in the UK. And I think that makes it very difficult to make the environment as safe as we'd obviously want it to be.
Yeah, and obviously that is alarming, because it probably means there's transmission of other things, you know, when people are in hospital for whatever reason, right? So,
Yeah.
yeah,
Yeah.
yeah. Um, so, yes, what is your view on delaying the second vaccine?
I support it. It's not, I mean, you know, 6 months time, we're not going to be doing it like this, but I think it is a reasonable thing to do given the objectives of the system. The objective in the first instance is to reduce the proportion of, reduce the numbers of people going into hospital with COVID. And I think it will allow that objective, whether it will enable that by getting, because most of the gain that you see is sort of 10 to 30 days after the first dose. And then the purpose of a second dose is to, it's durability and T cell responses that maintain your ability to respond. So I think it's extremely difficult, and I don't, but I do think that the advice they've had is good. And I think as a public health strategy, with the current prevalence rates, etc., I do support that. It wouldn't have been the thing to do in August probably, but we didn't have the epidemic that we now have in August.
So, there, somewhere someone suggested that this might, delaying the second dose might lead to resistant strains. Is this true?
That's been discussed, and the virologists and genomics people that I've been sort of particularly following do not particularly think that that's a risk in that kind of period of time. You know, so that's not. You will get, you know, we will get vaccine escape mutants, no question, that will happen. This new variant, the way that they think it's come about is probably where somebody's very ill for a long time and they're having lots of treatments, and then you've got within, you know, let's say I'm in ITU for 3 weeks with COVID, and then you know, really ill with it, and then my virus is evolving. So one of the things they're saying, well, you know, how do we need to manage people who are ill for a long time, because they are likely to be the kind of soup in which this grows. But that's not the same thing as vaccine resistant escape. So, you know, this time next year, reasonably likely that they will be saying, okay, well, we want to slightly change the bits of RNA we put in the viruses. That's to be expected. And I think that a kind of 8-week delay on second doses, you know, the other trade-off is that you could get that happening through more people getting it and more people being very sick. And there's a, you know, I think it's not, I don't see that as a kind of sort of, you know, as a sort of knockdown issue, really.
Great, that's good to hear. So vitamin D has been mentioned in the chat as well, as because that has been, in some research studies have shown that as a risk factor, right? Low vitamin D.
Yeah, I mean, I think it's been recommended for some years, and I can't remember the age ranges, that many people in the UK are vitamin D deficient. Partly it's dietary, partly we all have, I mean, we used to get a lot of it through milk, seafood and so on, but basically, most of it is being outdoors, and so older people and people who aren't outdoors much are at risk of vitamin D. The evidence for it being a risk for getting sick for COVID is, you know, people have always been looking for that. It would be lovely if it was true, because it's a nice, easy thing to do, but it isn't very conclusive. But I think it's very clear that many of the people who are at risk of COVID, getting very ill with COVID, are already recommended to have vitamin D, and that's for lots of reasons. And I would say that's even more true now that people are spending so much time indoors. And I think the other thing is that the darker your skin, the less, I mean, basically sunlight on your skin is what causes you to produce vitamin D, and the darker your skin, the less you will do that, because, you know, your skin pigments don't let the UV get through, because that's the whole point. And so it is true that Black and ethnic minority people, people with darker skins in the UK, are going to be more vulnerable, given the same life habits than other people, to having low vitamin D, which is not a good thing for all sorts of reasons. So just check whether you should be taking it for all the reasons that have been the case for a long time.
Yeah, no, absolutely. And the thing about darker skins is really, yes, I found out my neighbor has confirmed she's taking it, so I'm very pleased about that. So yeah, and you can also take excess. So people always read what the recommended dose is. This information is luckily available on NHS websites and stuff. So Sharon, because we're coming out, it was 1:15, so
yeah, I'm just actually there's no further apart from no, there's no further questions, but there's just one. It's not a question, but it's a comment. So I'm just going to read it out if I can find it again. There it is. And just see what you think about this one, Jackie. This is from Kevin, our doctor friend. I think the comparison to flu is misleading. While it can kill the vulnerable, it does not cause the potential long-term morbidity associated with COVID. Between 5 and 10% of sufferers develop long COVID, regardless of age or severity of initial symptoms. Some have developed long-term symptoms so severe they can no longer work.
Yeah, I mean, I got onto flu, I think, sort of largely through contact tracing. I completely accept your point. It was about sort of modes of control and so on. Absolutely. And I think, for example, I think we will get flu vaccination rates up. We need to get flu vaccination rates up because we want people to be as well as they can. But I completely take the point. Completely agree.
So I was going to actually ask you about long COVID. So thank you, Kevin, for bringing that up. What research has anybody kind of come to anything useful?
I think the research studies are really just beginning, and it's not an area I'm not doing that sort of clinical care. I'm not so much on top of. I know that there have been some commission studies that the UKI and NHR have funded some studies where they're looking at that, and obviously like immunologists and infectious disease people and all sorts of people will be contributing to those, but it's not an area that I've heard any that I'm well updated on.
Yes, I guess because the evidence was sort of only gradually emerging through the year, wasn't it, that people had longer symptoms?
I think there's, and there's two, maybe Kevin might want to comment here, but there's two things. One is the people who don't get desperately ill with COVID, but they get long COVID, and that's very disabling. And certainly I'm aware of, in my acquaintance, a few people like that. The other thing is, and I think it's, it's been increasingly recognised in recent years, is just how much, serious illness takes it out of you. When I was a kid, we talked about convalescence. A friend of mine was on ITU for something else like 2 years ago, and was just, the time it took just to get your muscles back. And so some of that's COVID, but some of that is just being really ill. You need to recover. And I think we've kind of lost that in the age of antibiotics. And I think there is something about convalescence and recognizing that serious illness means serious recovery time.
Yeah, thank you. That's borne out by someone I know who, is otherwise a sort of, a fit woman, and was like, why can't I cycle? I'll be out of breath every time I cycle, until the doctor said to her, actually, you need to take it easy for at least another month. And she did that, and that turned it round. But, she wasn't resting enough, basically.
Yeah, which it won't for everybody, but it is, it's important to recognize what you've been through.
Okay,
someone has asked, can we have the reference to the April 2021, I assume they meant 2020, the April 2020 available evidence, so we know what to look out for? Oh, no, and will Making Music present this evidence to members in some way?
I think this is 21.
What evidence?
I think it's, Jackie, what you were talking about, better data on the results of vaccinations, I think.
Yeah, and what does the impact of vaccines on transmission? Yeah, that would be really current in April, I think. Yeah.
Okay, so they're asking if we can have the reference for it.
Well, it's not available yet, but I can, you know where to find me, don't you?
Yeah, sure. Someone's also asked, can you have long-term COVID effects even if you've only had mild symptoms?
It does seem to be the case. It isn't just the people who've ended up in ITU. There do seem to be people who weren't seriously ill to start with, who then have long-term challenge. Oh, thank you.
Yeah.
Jonathan, really more on top of the clinical stuff, has put that in. Thank you so much. That's brilliant.
Brilliant. Okay, so folks, you can read up. Sharon will do her usual edit and send you a long paper to while away when the sun stops shining, and you want to learn even more about COVID than you already know. So anything else, Sharon?
That's it.
Brilliant. Well, I think we should probably just wrap it up there.